webinar. Our next slide, I think if you advance, shows our core team. There we go. So we have Caroline, who we could not do any of this without. We have Malachi and myself. Next slide. And then we also have quite a few partners now. As you can see, this slide has grown over time, which is pretty exciting. And so we're very grateful to have such wonderful partners as we start to grow this family-centered task force even further. And we also have a few grants that we're very grateful for as well. We're supported by Genentech, Prolacta, and then recently also had a Graven's Lunch session sponsored. And today we have two exciting presentations that you will get to hear from Dr. Smith and Christy Love initially, and I will speak in a little more detail about that in a couple of minutes to introduce them. And then our very own Dr. Balasundaram is going to be able to give us a talk as well. We will have specific question and answers after each of these sessions, and so please definitely chat in questions and comments as our speakers are presenting. And then we will have some time set aside after each presentation to be able to talk through some of those questions. We could not do this without our family partners. We have 17 family partners who are very active with our organization. And then we also have our healthcare partners as well that we see on the next slide, who are 16 very dedicated individuals that are contributing to the task force. And we have a couple of exciting updates to tell you since our last webinar. So most of these are related to the recent Graven's conference that was in Florida. I hope that many of you were able to attend it either in person or virtually. We were able to support 5 family partners to attend the Graven's conference virtually and 4 family partners, small group leaders, as well as 3 healthcare partners, small group leaders to attend the conference in person. In collaboration with the National NICU Parent Network, we were able to hold a task force luncheon that had 70 Graven's attendees and provide CMEs and CEUs for this attendance. And we also shared much of our task force work with the general attendees at Graven's on Friday in the form of a workshop, which was very interactive and a great way to hear how other people are doing things in their institutions and to share what our actual members are doing as well. And this last bullet point is really exciting. So a year ago, we had 50 individuals that were involved in this task force. And over the last year, we've been able to expand to over 415 individuals who represent over 200 NICUs from 36 states and 14 countries, all of whom are committed to learning more about family-centered care and really trying to advance this culture in their units and globally. And so now it is my pleasure to introduce our first 2 speakers. Dr. Vincent Smith is the Division Chief of Newborn Medicine at Boston Medical Center and a professor of pediatrics. He's a graduate of Texas A&M's University, Stanford University School of Medicine, and the Harvard School of Public Health. He trained in pediatrics at Children's Hospital and Boston Medical Center in the Boston Combined Pediatric Residency Program. He then completed a fellowship in neonatal perinatal medicine through the Harvard-wide program, a collaboration of Beth Israel Deaconess Medical Center, Brigham and Women's Hospital, Massachusetts General Hospital, and Boston Children's Hospital. He completed a fellowship in health services research at Children's Hospital and serves as the medical director for the AAP Fetal Alcohol Spectrum Disorders Program. He is an active member of the Massachusetts Medical Society and Society for Pediatric Research, and he's also a former member of the National Perinatal Association Board of Directors. In addition to parental NICU discharge readiness, his professional interests include families affected by substance use and medical care for LGBTQIA-headed families. And along with Dr. Smith, we have Christy Love, who is a mother of 2 preemies. For over 20 years, Christy has worked in the nonprofit community, providing health education, advocating for NICU families and the high-risk population. She's collaborated with community groups, corporations, national organizations, and universities to improve outcomes for families of premature infants, babies born with special needs, and developmental needs. So please join me in welcoming our speakers and remember to chat in your questions.
All right, can everybody see that now?
Yes.
Excellent. All right, so first of all, thank you all for having us and for your interest in this topic, because as you know, it's pretty near and dear to my heart and to Christy's heart. And so I think for it's hard for me to see the chat while while I'm sharing my screen. So somebody else will have to kind of keep an eye on the chat for me. And I'm going to do most of the talking for the presentation part, and Christy's going to jump in when to add extra detail, and also when there are questions that come up. And I also want to acknowledge Erica Goyer from National Perinatal Association, who helped make all of our slides look so much more beautiful than the slides that I initially created. So thank her for that. All right, so I have no financial disclosures that are relevant, and Christy has no financial disclosures that are relevant. And so we would like to acknowledge that the publication of the discharge guidelines supplements was sponsored by the National Perinatal Association, and the funding for the publication was provided to the National Perinatal Association by private donations and supported by an educational grant by SOBI. The funding for the implementation portion of the project was provided to National Perinatal Association by our partners, Angeli, who've been helping us on the second part of our journey. And I saw Jaylee is here. So, hey, Jaylee, thanks for being here. So during our time together, a couple of things. I want to kind of explain the importance of discharge preparation, which I'm not going to spend too much time on because I feel like I'm preaching to the choir when it comes to that. I do want to spend describing the creation of the guidelines and what the guidelines cover. And then I also want to talk a little bit about some steps for a successful implementation of the guidelines. And so, and this is mostly, I'm going to spend just a little bit of time and give a kind of high level view of that. And then if you want more information about the successful implementation, we're going to have to invite Kyler back because she's amazing and she does a great presentation. For those who are at Gravens, you kind of heard it. So this is going to be kind of the flow of the talk for today. So we're going to start off with a little bit with some definitions and the creation of the guidelines. And then we're going to review the topics that the guidelines cover. And there are like 200 plus guidelines. So we're not going to be able to go through each individual guideline in that kind of way. So what I want to give you is more of kind of a bit of a flavor for what the guidelines cover as opposed to specific guidelines themselves. And I'll tell you how you can get the guidelines and then also about some supporting material that goes with the guidelines. And then the last piece, we'll talk a little bit about implementation and hopefully we'll make it not seem quite as scary or as big of a task as it sometimes can seem when you're trying to implement something new. So the importance of NICU discharge preparation and transition planning. So normally I spend a good amount of this part of the time convincing you that it's really important to have discharge planning for the families and for providers. But given the audience, we're going to skip that part and we're going to just jump right into assuming that we all agree that it's an important thing. And so we will start off talking with two kind of related concepts. And the first one is discharge readiness, which is the desired outcome, and then discharge preparation, which is a process for people or families to get discharge ready. And so if we're talking about discharge readiness specifically, what we're talking about is the attainment of technical skills and knowledge, emotional comfort, and confidence with infant care. And this is by the primary caregivers at the time of discharge. And anybody who's ever heard a talk from me in the last 10 years knows that I use this definition all the time. I think this is really important. And then, so discharge readiness is the goal. Discharge preparation is the process. And so it's the process of facilitating discharge readiness to successfully make the transition for home. So with that in mind, we're going to transition to the discharge preparation guidelines. Don't you love how to work that in? So when we start to think about the guidelines, kind of like where they kind of came from in the ether and all of this, the original guidance came from the AAP. And what the AAP is the American Academy of Pediatrics. And what the AAP did was they described basically infant physiological maturity in pretty reasonable detail. And so what they said was that in order for an infant to transition from the NICU to home, the infant needs to achieve physiologic maturity, meaning that they can coordinate breathing and oral feedings, they can ingest adequate volumes and gain weight, and they can maintain normal body temperature, and thus they demonstrate stability. And so that's all pretty clear and pretty straightforward. And then the AAP said that parents should participate in a program for care of the infant at home. But what the AAP didn't do was give more detail about what the program should involve, how it should be implemented, or any of that things. They just said this needs to happen, and then they just left it kind of open. And the AP suggested that former NICU infants need to be followed in a medical home that is familiar with taking care of former NICU infants. And they said in this medical home, they need to be followed by a pediatric provider, and they need a program that's going to track the infant's growth and development. And so all of that is actually really good, but they don't talk about the transition from the NICU piece to this medical home piece, or any support services that come around the families after they're already discharged. So with that in mind, that's kind of what brings us to how the National Perinatal Association got into the discharge planning game. And so the National Perinatal Association developed these guidelines over many years, and they were using the best available evidence. And so I think everybody's familiar with the National Perinatal Association, but for those who don't know, NPA is an interdisciplinary organization and is one of the leading voices in perinatal care. And one of their missions is to bring parents and professionals together to advocate for better policies and care practices. The way the guidelines came about is around in 2017, the NPA convened a work group with the goal of creating a comprehensive set of guidelines that reflected the best available evidence from across disciplines, and it's also informed by families' experiences. And so families were always a part of this process from the very beginning all the way through. And so the process of creating these guidelines started with what's called an environmental scan, which is basically reviewing all existing standards and literature. And also the work group collected and collated existing standards and had a literature review of published medical and nursing literature that were related to this particular topic. And then using that environmental scan, that kind of became the basis for the first draft of the evidence-based multidisciplinary consensus guidelines. And then the work group determined where consensus existed, recognizing that there were some differences in practices. And then they also tried to identify gaps with no guidelines available, and then kind of created a course of action to be able to address what the gaps were. And then in 2019, the National Perinatal Association hosted a summit of content experts whose express purpose was to review the draft of the guidelines that the work group had created. And prior to the conference, the content experts were divided into 4 groups based on topics. So it was family and home assessment, special circumstances, support systems, and or transfer and or coordination of care. And each of those groups was given the questions: is this content appropriate? Is this content complete, or is there missing information? And also, are the recommendations appropriate, practical, and actionable? Are the recommendations clear and concise? And are the recommendations comprehensive and complete? So that was the pre-work that folks had to do coming into the summit. And during the summit, which consisted of 16 multidisciplinary experts representing 14 different organizations, they reviewed their assigned sections of the guidelines. And at the end of the summit, each of the group produced a report and devised next steps for their draft of the guidelines. And then a select group of content experts went back and verified each of the references associated with the guidelines from the original article or guidance, and assessed the level of evidence for each of the items. And then in January of 2021, NPA hosted a second national summit after all the work was done between the first summit and the second summit. And this national summit consisted of experts that reviewed the revised version of the guidelines. That summit consisted of 22 multidisciplinary experts that represented 19 different organizations. And similar to the first summit, the content experts were assigned, this time it was 5 different topic areas instead of 4. And during the summit, the content experts reviewed their assigned sections of the guidelines with the same questions that we had from the first summit. And at the end of the summit, the group of experts produced a report and devised next steps for the draft of the guidelines. And so that report is what was used to make the final form of the guidelines, which were created and published. And that's where we are. That's where we are today. And so the goal of these guidelines is to support the families and to assure that they have the skills, knowledge, and confidence that they need to be able to transition successfully from the NICU to home. You should know that these guidelines are free and they're open access. You can just come and claim them, you can use them. And in addition to the guidelines themselves, There is a companion website, which we're going to talk about, but you'll notice it's on the slides, NICU2home.org. And we're going to talk a little bit about that after I run you through the guidelines. So when we're thinking about the guidelines, they're divided up into the topic areas: basic information, anticipatory guidance, family and home needs assessment, and the transition and coordination of care. And as I mentioned a couple of times, there's over 200 of these guidelines, so there's no way we're going to be able to go through all of them. And I'm not even sure it'd be worth your time for us to sit here and do that together. And so instead I'm going to try to do is give you a flavor for what each of the sections cover. And then from there, we can talk a little bit more about like how to kind of use these guidelines. And so the first section of the guidelines is what we call basic information. And what we covered in this particular area is things that every family in the NICU should know, regardless of if they're in the NICU for, 3 days or 3 months. And so it covers things like goals and timeline, like when things need to happen during the course of your NICU journey, and a curriculum for the skills and the knowledge that the families need to acquire to help them make the transition. And then it discusses discharge education strategy, which is going to be your approach to helping the family with the education curriculum. And then it also talks a little bit about supplemental material, because in most instances, bedside teaching is going to be like the #1 method of conveying information. But then in addition to the bedside teaching, there's going to be potential websites, there can be digital teaching, there can be videos, sometimes there are papers, folders, binders, and so there are a lot of other ways to get supplemental material to reinforce the information that's given right at the bedside. And then in addition, basic information also covers infant care skills demonstration, and that goes into a little bit of detail when you're actually doing the teaching and the teach back and confirming understanding. And it discusses like safer sleep practices, car seat, car bed installation and safety, and then understanding what some typical and atypical infant behavior are, because sometimes, especially former preemies, their behaviors may be slightly different than what you'd expect for term babies that are the same age. The next section of the guidelines covers home and family needs assessment. And this is to give this gives individuals an idea about the family structure, the family support, the family's learning style, and other factors that could impact how your discharge preparation process is going to go. And so in this section, they look at family assessment, which is looking at like who's in the family, who are going to be the care providers, who are going to be the primary providers, who are going to be the other support systems. It looks at caregiver mental health, both at the time of discharge planning, taking into account past mental health issues, and also raising awareness of potential mental health issues for both the caregivers and for the infant that may come up later. And also it has a little bit of anticipatory guidance, but there's a whole anticipatory guidance section that we're going to talk about independent of this particular section. The next section of the guidelines, we talk a little bit about transfer and coordination of care. And what we found in our work is that traditionally this has been an area of really pretty significant weakness and or challenge when it comes to the discharge planning process, because oftentimes people think, okay, when they leave the NICU, cut the cord, the end, and our work here is all done. And so for a family, though, that's not how they experience any of this. And so what we strive for is to have basically a continuum from NICU to home and have it be a seamless transition between both the providers that are taking care of the infant and the family, and for the family, so that they don't feel like they're just dumped by the NICU, which is often how families feel. And so in this section, we talk a little bit about the importance of primary care, pediatric primary care providers, and the medical home. And we also help the family to understand the role that the medical home will play kind of in ongoing care and with care coordination. And we talk a little bit about use of navigators and navigating the hospital system for appointments and things that follow up after NICU discharge. We talk about in this section, we make some recommendations about communication among NICU providers and community providers, as well as communication between families after discharge and the NICU. And we strongly encourage more integration of the NICU and community providers in ongoing care together. In this section, we also explain like the potential for subspecialty needs and how to talk with families about that. We talk about things like routine home visiting. We talk about follow-up programs like early intervention. And then we talk about ways to communicate information to the medical home and to subspecialty providers. And one of those methods is the discharge summary, where we talk about some specific components that the discharge summary should include for clarity and for the sake of transition. And then the next section of the guidelines talks a little bit understanding what the family's support systems are. So you can put in place, you can help the families to get in place any types of support that they're going to need to be able to successfully make this transition. And some of the systems that we look at are peer-to-peer programs, how to safely use technology, the role of social worker and potential social worker involvement, because for some families, social work is kind of like almost like a bad word, and we try to not have it be framed in that kind of way and not have the social work interaction be in that kind of way. We talk a little bit about mental health support, because sometimes mental health issues can arise, especially for fathers and partners, in a very different way than what they would for postpartum birthing people. We talk about communication post-discharge, mostly communication between families and NICU providers. And then we talk about use of community programs for potential support for families. And then the next section of the guidelines, we talk about anticipatory guidance. And what the goal for this whole section is to give the families a more realistic idea of what their life is going to be like with their new addition. And this is both in the short term, like in the days and weeks that follow discharge, and more in the long term over the course of the next couple of years as the infant grows and develops, the kind of things that they look for. And so part of the goal of this section of the guidelines is to help families understand how they parent a NICU graduate. And it may be slightly different than parenting a non-NICU graduate. And we talk about helping them to understand how their baby's development and when they're going to reach their milestones, what their baby's follow-up care will look like how many appointments are they going to have, and are families, are they going to be providers coming to the house? Are they going to have to go to offices? And then we really stressed the importance of a medical home to help the families, not just with the direct medical care, but also with coordination of care, especially if subspecialties are involved, if the baby has any kind of complex medical needs or any kind of ongoing medical needs or any medical equipment. And so those things, like sometimes people don't understand the role that medical homes can play and the help the medical homes can provide. And then the last part, we also want families to understand and address their own psychosocial needs, because many times these things never actually get addressed or even mentioned. And especially for husbands or partners, or for fathers or partners, regardless of marital status, sometimes this isn't even addressed. In addition to all of these big pillars that we've just talked about, there are also some other circumstances that have to be taken into account as part of your discharge planning process. And so, because these things will, you need to be aware of, because they may affect what you do during the discharge planning process. And so one of the first ones is families who prefer speaking other languages. And so in this section of the guidelines, we talk a little bit about interpreter use. We specifically address when it's appropriate to use family members as interpreters and when it's not. We talk about using computer and things like Google Translator without specifically naming Google. And then we talk about hospital navigation when, the preferred language for the family is not the prevailing language of the area that they're in. And then we talk about the importance of social support and also primary care options for families with limited English proficiency. And then for military families, we talk a little bit in this section about follow-up considerations, how follow-up happens. We talk about the moves that are not often inherently part of being a military family. We talk about TRICARE insurances and some of the pros and cons that come with that, considering a lot of military families, or the majority of military families, are on this TRICARE insurance. We talk about home visitation and what that looks like for military families compared to non-military families. And then we talk about information sharing, because it matters quite a bit if you're a military family in a military hospital or a military family in a civilian hospital, or if you go back and forth between different types of facilities, which oftentimes military families do. And then for LGBTQI plus headed families, we talk about the importance of designating who the caregivers are, understanding what parental roles are, and understanding parental rights and acceptable terminology and acceptable questions versus non-acceptable questions. Then for parents with disabilities, in this section, we talk a little bit about some family literacy, accessibility issues, both in the hospital, in the NICU, and home, as well as home environment preparation, meaning getting the home ready to be able to successfully parent an infant at home, and some factors that should need to be taken into account, like possibly an OT assessment of the home to make sure that it's appropriate. And then also an assessment of caregiver ability. And then in the section where we talk about families with distinct cultural and or philosophical expectations, in this section, we talk a little bit about family belief systems. We talk about family support people. We talk about cultural practices, and then community resources and how community resources may interact in a way that's culturally sensitive. So all of those are important considerations that you need to take into account when you're doing your kind of discharge planning. So what the ultimate goal for the guidelines are is, because we cover a lot of territory, I told you there's kind of 200 of them, but it really boils down to what every family is going to need to know and what families are going to need to be ready for, having an idea of what their day-to-day life will look like and who's going to be part of the team. And so that's kind of a summary of what all the guidelines go kind of cover without specifically looking at the individual guidelines. All right, so this is what I promised you earlier in the talk. There is also a companion website, so you can write this down and check it out. It's the NICU2Home.org. And what's really cool about this website is it's created by the National Perinatal Association, and it's like kind of a living place, and it's intended to be a repository for tools and resources and a community of experts who are all interested in NICU discharge planning and discharge preparation. It's a place where you can come and look for information, or if you have some suggestions or ideas or things that work for you, you can come and share those, so then they become available to other people. And so it's our kind of way of like making this whole implementation of the guidelines be a little bit easier, because if one person has figured out one part they can help with, and then another person figures out another part, then another person figures out another part, and you put them all together, then it makes it easier for the next group to come along and to be able to implement what these guidelines say. And there's no reason to reinvent the wheel every single time. So, but what do we do next? So the guidelines were finished, the guidelines were published, the website was created, tools were put up on the website. And then as one of our work group members, Julia Yuri, says, we did not create these guidelines so they can sit on a shelf. And so what we really want is for people to be able to get these guidelines into the hands of people who actually have an ability to make a difference in the lives of families, because we really do believe that these guidelines can help. And for anyone who's been through the NICU who didn't have really specific guidelines, the transition probably wasn't as ideal as it could be. And so that leads us to talking about implementation of the guidelines. And so when we think about this, it's like, what do we do to turn these recommendations into actions, and what do we do next? And this can be a pretty daunting task, and we acknowledge that. So our work group, once the guidelines were created, our work group turned to focusing on how we can help with the implementation and understanding the guidelines are written in such a way that they're general, meaning that they can apply to a bunch of different circumstances, because the personnel available in any given NICU, the patient population, and the types of providers and the types of patients, the number of patients, those are going to vary quite a bit across NICUs. And there's no way we could do like just one-stop shopping, like push if this, then do this. And so what's going to be required in order to be able to implement these guidelines locally, you're going to have to look at and adapt them for whatever your resources are available to you. And so, but that can seem scary. And so anybody who's at Gravens, there was a mom there named Mia Malcolm, and one of her quotes was, "We're not asking you to boil the ocean. We just want you to start with a pot." And so the truth is, everybody has a pot that they can start with. And so for these guidelines, even though there's a bunch of them, you can pick one that you're passionate about, one that you care about, and start with that. And then once you're able to successfully and sustainably implement that, move on to the next, and move on to the next. And before you know it, you have a whole package of discharge planning that you've kind of built up. And so I'm going to talk a little bit about just one person's implementation journey. It's Kyla Romeo, and she's just an excellent, she's part of the work group, and she's just an excellent example of what one person who's motivated can do. And so she's an OT, and she works with Feeding Matters. And she's at Banner in Arizona. And I'm going to talk a little bit about that in some of the upcoming slides. And so a couple of important pieces about her, she's a former NICU mom. She's OT, a feeding specialist, has had years of working in the NICU, but what she didn't have is a background in implementation science or healthcare quality and improvement. And so she was a motivated person who thought that this was a really good idea and thought there was potential benefit to her unit in doing this and to the families that she takes care of. So she relied on open access tools for healthcare quality improvement and dissemination science. And she was able to do quite a bit with just those open access tools. And so just before we jump into what exactly she did and how she did it, let's talk a little bit about what her unit is like. So she's at Banner in Arizona, which I told you before. And so it's a community hospital. It's a level 3. It's got 42 beds present. And it serves Southern Arizona and several rural communities. And she describes her population way better than I'm ever going to be able to describe it. But you name it, they have it in that unit. People travel for hours sometimes to get there. They have really complex patients, and so all of those things are kind of really important. And the way she kind of began this was she put together a group of invested stakeholders, and she used already existing infrastructure and relationships, meaning that like she didn't come in and try to create something brand new. She had a parent group who was already interested and active. She had a group of nurses and therapists who are already interested and active. She found a neonatologist who was willing to come on board and believed in what she was trying to accomplish. So she pulled all of these people together, and they formed kind of a think tank. And then she said, okay, with this group of stakeholders, with this group of guidelines, can we pick one, maybe 2 things which are really important to our patient population, maybe something that we're not doing as well as what we would like to do, and let's try to focus on those, and what things would make a meaningful difference to our population. And then what kind of metrics would we use to measure our success so that we can know not just for ourselves, but for others, and like people who are clinically at the bedside, people who are in administration, people who are going through the program, who are experiencing it as families. And so what kind of outcomes are going to be important, and what kind of metrics are going to be important for us to be able to show that we're being successful with these things? And so what she chose was access to early intervention services, because what she was finding is as a place to start, was a lot of families are leaving the NICU, but not connecting with early intervention services. And this is including people who would qualify for early intervention services. And then, given that she's an OT and Feeding Matters is her organization, identify feeding needs and risk factors. And so she chose to implement these things because they're related to topics that her unit cared about, and they had metrics that they could measure that they could track for success, with early intervention, referral, and assessing services and assessing feeding risk, and documenting the assessment of the feeding risk and using that for early intervention. And just to prove the power that one person can have, this is a really, really, really busy slide, but all it says is that when she decided that these were the things that she was going to focus on, she was able to make a few phone calls to local agencies. And it's amazing how making one phone call suddenly removed barriers. She discovered that there was an individual who could help with referrals to early intervention, both making them and following them up. And that person, wasn't getting the referrals. And so just connecting her unit with that particular individual, referrals went up from like 10% to maybe 40%. So it was like don't quote me on that exact number, but it was the order of magnitude of change was just to that huge degree. And then she found out that many kids who met requirements for services, meaning they've been evaluated by a therapist and found to have a challenge that they would qualify for early intervention services, they just weren't getting referred to because people weren't aware that the feeding challenges that they were coming up qualify people for services. So I'm not saying that this is what you need to do in your specific unit, but I said sometimes just having one person making one phone call and having one discussion can really change outcomes in a huge way for folks and for individuals. So then what Kyler was able to do was to go online, because remember, again, I told you, she didn't have any training in dissemination or implementation models, but she was able to go on site to this website, dissemination-implementation.org. And what she found was that there are a bunch of free tools that she could put in the things that she was trying to measure, what she was trying to do. And it kind of, in a really simple and straightforward way, walked her through the processes that she would need for a successful implementation and use it to be able to assess how the implementation is going, thus helping to maintain a sustainable program. And so this is an example of some of the tools that she was able to access that help with the planning. And so this was one of her challenges, like infants are referred to community services, NICU, developmental clinic, NICU follow-up, but the services are often not rendered. And why? And in using these tools, she could kind of help trouble set why this, even if the referrals are happening, not that all the referrals were happening, but first to get the referrals to happen. And then when they did happen, how come the services are not getting rendered? And then there are tools to understand what the needs. And in this particular instance, what the tools were divided up into 3 different categories: processes, providers, and parents. And we'll talk about those really on this slide. So in relation to what the guidelines were and what their goals were, processes were things like discharge summary, approved assessments, and education. Provider information with things like medical record, point of contact, referral pathways, and follow-up. And then the parent piece was parent education and advocacy, was education, integration, and advocacy. And so those are ways that they kind of translated the guidelines that they were working with into these tools that they were using and how they could help with their implementation. So what was your greatest worry? And I think that in starting this work, they were really intimidated because it was doing something new, and they were worried about what was going to be their ability to be successful. And then in doing this, I think they were pleasantly surprised at how much one person could actually do and how much change could come about with one particular person. And this was a pilot study, meaning that they decided they were going to pick 1 or 2 guidelines to start with, using these resources that are already available, and then supplementing with the online materials that were free and readily available to them, and working towards goals that were already kind of important to them. And so for them, for their next step is they're going to refine the pilot a little bit more. They're going to continue to collect data with the pilot, and then they want to expand the pilot because, again, like I said, they started with 2 things and there's over 200 guidelines, and they want to expand it because as they noted that they were able to make success and make measurable, meaningful success with the things that they were doing, then people became excited about the success, and people became excited about the potential success. And so that got people on board to want to do more. And then they want to assess what their outcomes look like and to make sure that what they're doing really is as sustainable as what they hope it is. And then hopefully, they made the one partnership, which was hugely key to being able to connect with outpatient services, which was one of their goals. And so they're looking for other partnerships in other ways and making use of other resources, which could be underutilized because people may not be aware of them or know how to use them. So anyway, that was not meant to be a course on how to do implementation, but just an example of what the power of one person who's motivated can do. And so I say that so you can feel empowered to kind of do things and know that you aren't alone in necessarily doing this. There are other ways to help, and National Perinatal Association is one of those. So I'm going to stop talking because I was supposed to only talk for 30 minutes, and I think I went over just a little bit. And I want to thank all of the steering committee who worked on these guidelines, who produced the guidelines, and all the content experts who contributed to being able to make this work happen. And I want to thank you for listening, for your attention. And Christy and I are happy to take some questions, and I'm going to stop sharing.
Thank you so much for that fantastic talk. We have had a few things in the chat that have come up while you've been showing us your slides and talking through this tool. One of the things that has come up is when is the correct time to measure parental readiness for discharge, and whether parents really know that they're ready for discharge prior to going home, or whether it might be a better idea to evaluate that after they've been home and are able to actually assess if they've been made ready. And so I'd love to hear your thoughts and
My
Christy's
thoughts on that.
on that.
So that's I love how they frame a question as being simple when it's actually really, really complicated. And so I would say there's a couple of ways to do it. And I'm gonna preface it. Christy, you should unmute and jump in here too if I'm messing something up or I'm leaving something out. I don't know that there's a magic correct time or a magic incorrect time. I think for sake of ease, oftentimes it's easier to assess their discharge readiness like right before they go home while they're still in the NICU. And so ideally, like after all the discharge teaching has been done, which means that you can't wait till the last minute to do all the discharge teaching. Otherwise, there's no time to get it in and assess and have them leave. And so ideally, you'll have a timeline. You'll get the discharge education pieces done early enough and skills demonstrations done early enough and signed off on all these things early enough that you could assess them right before they go home, because that's the time when you're most likely to get most of them. But it is true that like at the moment right before they go home, they're probably at a bit of a high. They're excited, they're nervous because they're leaving, but they're also excited because they're going to be going home, and it's really kind of a mixed thing. But they haven't been at home doing primarily providing all the care for the infant yet. And so sometimes how you feel in the moment and how you feel after a week of doing that is a little different. And so in that regard, like, assessing what the discharge readiness is like a week or two after discharge, then you probably get a more realistic idea of how people feel about their discharge preparation at that time. The problem is people are really busy at that time taking care of their infant, adjusting to, the addition to the family. And so your response rate is probably going to be a little bit lower. And you could make the argument that like, if you assessed 4 to 6 weeks after discharge, after people get over the initial shock and awe of being at home and like, oh, I can't believe I'm actually home and I have this baby and I'm doing it. And so, I think that then they've had a chance to kind of settle in, reestablish a routine, and they've kind of figured out a lot of the initial challenges that are kind of a little bumpy in the few days right after discharge. And so that could give you a better idea of kind of long-term what it meant. And then if you assess them at 6 to 8 months afterwards, then you can get an idea of what the retention of the information really is like. And so that was a really, 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 really long answer to say there's not really a magic number, and there's pluses and minuses with whichever way you decide to do the assessment. And so I think it's probably more important to do an assessment in a consistent way. And so that way you get relative comparisons again and again and again. And whichever time period you pick, there's good arguments for either time period. So, Christy, did you want to add anything to that?
I think you covered the majority of it. I'll just share as a NICU parent, no matter how much education and preparation we have, or we think that, or the staff feels that we have, we really don't, because once we walk out those doors, we're leaving our support system and knowledge back in the NICU. So community resources is a huge piece that I think a lot of institutions are missing, communities are missing, because having your community resources is going to help that transition.
And I would definitely recommend to those of you that haven't, reading through the chat, and we'll make this available as well. We've had some really great examples and stories that have been shared from our family partners that are on the call. And at least in perusing them as they've been coming through, I have to say there are probably a lot of areas we can improve. There have been a few that have stated they had a good experience, but maybe still had some issues with things like feeding supply companies and whatnot. But certainly sounds like we have some room for improvement with discharge readiness. Another thing I would love for you to speak about, and others please put some questions into the chat as well, is you really emphasize that medical home. And I wonder if you could define a little bit what you mean by that, because I feel like medical home could be a different group of individuals depending on resources in the community and where people are being discharged, and how maybe they could bridge this support gap that we're talking about of parents leaving the NICU and kind of feeling that they're adrift at that point.
Yeah. Chris, do you want me to take that one, or you want to take it?
Go ahead.
All right. So I think when we're thinking about medical home, we're thinking about a place that serves kind of multifunctions. I mean, it's a place that you have to feel comfortable asking just kind of general questions, because especially when you're home with a former NICU baby, there's some things that you're just not sure if they're going to be normal or abnormal, and it's going to take a while to kind of know that. So you do need a place that you can get kind of like that baseline level of, is this okay? Is this not okay? And then you want to have a place that's going to consistently monitor your growth and development of the infant, and be able to know that when they need to do interventions. And so, because there can be ongoing issues, specifically feeding issues and specifically growth related issues, and then as the kid gets a little bit older, sometimes there are behavioral challenges and learning difficulties that kind of come along. And so you want a place that's going to kind of understand that and be kind of your partner in working with that, and can also help with you if you need that for advocacy for services, whether it's early intervention services, or whether if the kid is a little bit older, like school system services. And then also a lot of former NICU babies have complex medical care, meaning that like it's not just their primary care that they're seeing. They see endocrine, or they see renal, or they see cardiology, or they see infectious, or they see whoever, all these other litany or speech and OT, and all of these other litany of services. And it's, as a parent, it can be kind of hard to kind of keep track of all of those things, and to make sure that all the referrals are in place, and that all the recommendations are being implemented. And in theory, your medical home should be able to help you with that, because you shouldn't have to kind of manage all of that stuff by yourself. They should help you track appointments, and when there's feedback, from the appointments, how to implement that and make sure that that's getting taken care of, and making sure that all of the infant and the family's needs are kind of getting met. And so sometimes a new need will come up that hadn't been anticipated, and you'll need referrals, and the medical home should, in theory, be able to help you make the referrals and help follow up with what the recommendations are from the referrals. And so the whole point with the medical home is it can be, what that looks like can vary a little bit. There's no this is only what a medical home looks like. I mean, it can be a pediatric provider, it can be a pediatric practice, it can be, oftentimes though, it's more than just the pediatrician, because sometimes you have some of the nurses who are discharge coordinators, or case managers, or social workers, or psychologists, or therapists, all these other people who can kind of help with some of the other heavy lifting, and help when kind of questions or challenges arises. And so it's more, I think of it could just be your pediatrician, but sometimes it's more than just the pediatrician. Is that kind of, I feel like I'm giving really long answers to these questions.
Well, it's because we aren't asking simple questions, right? No, that answered my portion of the question, definitely. We have about 2 minutes before we're going to go to Dr. Balasundaram, and we just had a question come through. How do we build out a medical home for underserved areas and rural areas? So I'm going to challenge you to try to answer that one in 2 minutes, because it's important.
Yeah, so I think whether it's an underserved area, whether it's a rural area, whether it's an affluent area, I think really realistically what you're gonna have to do is an assessment of what the resources are that are available at that given, and that's gonna vary quite a bit, a lot, depending on where you are and what that place is. And then you have to map that out to what the specific needs are. And then regardless of what's available, if it's not going to be available to you kind of locally, then you have to look kind of what are other ways through maybe telemedicine or remote health that you can get some of these other needs kind of met, and what are the kind of supports that are available to you. And I say that because sometimes there are national things that are available and accessible to kind of supplement, and it may not be as robust as being able to go to a place that's right across the street from you, but if that place is not available to you, it's better than nothing, if that makes sense. Consultation with a developmental pediatrician 200 miles away, over telemedicine is probably better than not having any consultation at all. I mean, although it would be preferable for you to be able to go across the street to your developmental pediatrician and have them see you and your baby and to make the assessments and form a natural relationship with you that way. Sometimes it's not going to be available. I think the thing that matters the most is having somebody who really cares and who's willing to get in there and help, because I think that makes a huge difference.
Absolutely. Well, thank you so much, Dr. Smith, and also Christy, for this talk. And I'm going to pass things over to Dr. Ballasundram.
Hey, thank you so much for having us.
Can you guys hear me okay?
Sounds good.
Okay, great. Hi, everyone. Thanks, Vincent and Christy, for sharing your wonderful resources to our community. And Vincent, I used many of your publications while building this program. So thank you for all your work and the discharge planning and preparation. So that's wonderful. So I'm going to talk about our local unit-based program that we built for our NICU families. So next slide, Carolyn. This slide lists are my talk learning objectives. I'm not going to go read those bullet points. It's basically, I'm going to start from our journey, which began in 2017, and we completed our journey in 2019, and how we are sustaining the program. And I can give you a demo of our education activities under the MyChart bedside. Next slide, Carolyn. Okay, so this is the picture of me with Dr. Carrie McCauley, and she is my partner in crime. And so she is a neonatologist, an epic physician builder. And she is supposed to be, she is in sabbatical, and she said she won't make it to this meeting, but lucky for us, so she joined. And so if you have any specific questions related to the epic and MyChart bedside, and here is her contact information, and she is available for you to ask any questions, and if you are thinking of implementing this program in your unit. Next slide. So in this El Camino Health is the 20-bed community level 3 NICU. So we provide cares for any infants 23 weeks and above. And we are an open bay unit with approximate delivery volume of 4,500 newborns and average 400 NICU admissions per year. We are staffed by Stanford neonatologists and nurses and auxiliary staff, and we do have a resident, Stanford residents and medical students that rotate through our unit. We don't have any fellows or advanced practice providers in our unit. Next slide. So I don't want to spend more time here. And I think Dr. Smith clearly described why we needed to focus on this. And we heard about our multiple family partners, about how they felt about the discharge planning and post-discharge. I just wanted to briefly talk about, and if you are not adequately preparing families, so that contributes to the poor infant outcomes and heighten the family anxiety and increase the healthcare utilization after discharge. As Dr. Smith mentioned in his talk, quality of discharge teaching is the strongest predictor of discharge readiness. With this in mind, so we built our program so as a part of the Family Centered Care Committee. Next slide. So we looked at our, so we built our Family Centered Care program in 2016, and the beginning phase, we actually looked at improving the discharge education. So we looked at our Press Ganey, and some of you are familiar with this, but if you have international colleagues, I just wanted to share what is the Press Ganey. So this is the patient satisfaction survey their families usually get after discharge. And we have our NICU specific Press Ganey and survey that goes out to the families by mail, and we are actually working on making that as electronic format. So this survey, we looked at our prepared for discharge top box responses. That is the response that reflects the highest possible rating. So we looked at, and our rating was 47% in 2017. So we looked at the other categories. We were scoring anywhere 70%. So this is the lowest of 47%. So we wanted to improve by using a technology and providing a consistent discharge teaching. And the goal is to start this process closer to the admission time and not waiting until the last few days of hospitalization. Next slide. So this is just a screenshot of our NICU survey. So we used a 4-page document in the beginning of the journey, and then I consolidated, worked with the Press Ganey and patient experience. We consolidated this into 2-page. It focuses on different categories: nurses, doctors, and discharge, and overall assessment, some specific to our center. So this survey usually sent out within a month time period to the NICU families. Next slide. So this is a flow diagram, and so it focuses on multiple interventions that we followed in this improvement of journey. The first intervention, next slide. So we formed a committee. So we formed the task force. So it's called a Comprehensive Discharge Teaching Task Force. So this, as you can see in this slide, we have a wide range of providers, from bedside nurses, nurse practitioners, nurse manager, neonatologist, and families as a part of the member in this task force. Next slide. So once we formed the committee, so we wanted to work on the unit-specific discharge teaching. So the team members actually wrote a unit-specific discharge teaching. We had some old discharge teaching also, so we just modified that. And we created a videos for important discharge teaching sections, like how to use the bulk syringe and how to measure the temperature and car seat and mixing the formula. So we just asked the families what they wanted to hear from us. So we included their feedback, and we created a video, and we created our El Camino NICU Gmail account, and we uploaded that into YouTube, and we linked that YouTube into the ebook content. So it went through several revisions. We accommodated the Family Advisory Board, and we used to call Family Advisory Board. Now we are calling it Family Partnership Council. And so originally we thought we can build this as a Word document. And then with the Word document, it's not easy to navigate the table of contents. So I just converted that into ebook using an iBook author application. Now it's called Apple Pages. So in this way, it has a table of content. I will show the picture in the next slide. So it's just gives a table of contents, and parents can review this, and then so they can go back and review their content at their own pace. So we had 3 iPads donated by our Family Advisory Board. That's how we started this project in the beginning, using the 3 iPads. Next slide. So the next intervention, so once we wrote the ebook, and then we wanted to implement that ebook, and then how we can make sure it reaches to every families. We focused on that as a second intervention. Next slide. So here you can see the content. So the old picture on the left is the discharge teaching on the ebook and iPad. So there's a table of content. We try to match that. We matched We matched the content to the electronic health record, what the nurses are looking at on their end. So we matched the content with the order, how it appears. And we created a paper checklist. So the paper checklist was placed at the bedside, and it matches the content of the ebook too. So whenever the parents review this information, they can actually sign off on the paper checklist, and the nursing staff can add that information into electronic health record. So it was manually transferred by nursing staff in Epic. Next slide. So the next intervention is like, okay, so the previous one, the nursing staff has manually need to input that information, and you have a paper checklist, and we did the audit and making sure it reaching to every patient, but still we are not able to achieve that. So the next intervention, next slide. So we had only 3 iPads in the unit, and so if there are 20 patients there, so we don't have access for them to use it. So what we did is we actually created the PDF of our discharge education and uploaded into our hospital website. And so that way the patients, families can have access to this information. So they can review this information while they're at home. So when they are here, they can just focus on providing a care to the babies, and instead of sitting and then reading the information. So we uploaded that on the website with the help of our marketing team. And so they can review that information and come to the unit and then check off on the paper checklist. Next slide, please. And during this intervention also, we created a homecoming checklist. So what it is, we usually give this information like a few days before the discharge. It has a checklist for the families to go through what are the things they need to buy or bring in on the day of discharge. So just to help them prepare, bringing the car seat and installing the car seat information and all those things. So it was created by one of our nurses, Michelle Wrench. So it's really useful to give this information just a few days before the discharge. The parents can prepare. Next slide. So the next intervention is, so there's room for improvement, right? So from the previous intervention, the nurses staff has to manually enter in the Epic, and it's only we had 3 iPads at the bedside. So the iPads are not available frequently for some of the families. So lucky for us, our hospital actually did the pilot study to include the MyChart bedside as a part of the pilot to the NICU. So we had we received 20 iPads. So each baby get their own iPad. So we actually pilot that MyChart bedside, integrating the ebook content into the MyChart portal. I will share that in the next slide. Next slide, please. So this is a MyChart bedside screenshot. So basically, it's a tablet-based application that gives admitted patients and their families more information about the patient's condition and hospital stay. So as you can see, they can review their treatment team and who's taking care of their babies. And so they can look at the vital signs and lab work and problem list and what are medications the baby's on. So all those information is available on their iPad and the MyChart bedside. So under this MyChart bedside, there's a section called To Learn. That's where we uploaded all of our ebook discharge education into that To Learn section. Next slide. So this is where the families look at this information on their iPad. So under To Learn, it opens as a book. It's a newborn discharge education. It has a different chapters. It divided into 6 categories, and so they open this each chapter. So next slide. Once they open the chapter, so this is what they are seeing it on their end. So each chapter has the written material, and also if applicable, there is some picture, and also there's a video incorporated. I can just play this video. Hopefully it will work.
Wow. To bulb section your baby, you're going to take your bulb section, gently press down with your thumb, put it in your baby's mouth in the side, release, and then put any mucus or secretions on a cloth to the side. You're always going to do the mouth before you do the nose. So to do the nose, you'll do the same thing, 1 nostril at a time, gently insert the bulb suction, release, and then put any mucus or secretions to the side.
So next slide, Carolyn. Okay, so this one, MyChart bedside is looking at that while they are in the NICU. So because they can't take that iPad to home. But if they wanted to see this information on their own mobile, so they can use this as a MyChart mobile app. So in the App Store, so they can download the MyChart, and so they can pick the organization, whatever they are. So for us, it's El Camino Health, and so they can log into the mother's MyCare account, and it's a proxy, then switch to the baby. They can select the menu and type education, so they can just look at the education. So all the material that is on their MyChart bedside is available for them to review on their phone in MyChart. So that way, if they wanted to review this on their phone, so they can do that. And so they don't have to use the MyChart bedside. MyChart bedside app, and they can actually bring, if they have an iPad or laptop, they can bring that, and we can actually use their device to scan the QR code and activate the MyChart bedside, so they can keep that account active even after the discharge too. So all the information will be saved, and so they have a full access to their baby's information, labs, vital signs and everything, and now they can even look at our notes once we signed, and so it just flows to this MyChart bedside, and so they can review and read our notes. Next slide. So we received this 20 iPads. So we wanted to take this as a pilot project. So what we did is the ebook content and transferred to learn section of the MyChart website. So the discharge education checklist so was manually assigned to patients by nurses. So you could have imagined that how it went. And so it just every patient needs to be assigned manually the discharge education. And it's time consuming for nurses. I can show the data on how we did this pilot phase. And so we wanted to make it better. So we wanted to improve. So the next phase, next slide. So this is how it works. So what they do is the patient review this information. In like example, the taking a temperature. There's two boxes on the bottom. So one is I understand. The other one is that I have a question. So if they understand the concept, they can just click that I understand. So then it flows directly to the Epic electronic health record, and the nurses can review that information. And so just if they have any questions, they can put I have questions. So then it flows as a yellow highlights, and then it's not complete green circle, it's just giving an orange circle. So this way, the nurses can see whether this family participated in the education and how far they are behind or how far they are completed. And so they can just gently remind them to complete that education just to be in advance. So not on the day of discharge. That's the beauty of this phase. They are able to look at this and then communicate with the families. Next slide. So the next intervention, as I mentioned, that intervention, the nurses actually needs to assign the checklist. And so in order for them to get the families to see this information on the MyChart website, which is painful. So we just wanted to get it better. So we optimized that MyChart website portal. Next slide. So in this optimization is where our Epic Physician Builder, so Dr. McCauley did a beautiful job of creating this content of what are the information we wrote in the ebook. So it's just each education section given a point. And so we have a full discharge education points. And so there's a separate section for the readmission discharge education points. We don't want the readmission families or short stay families to look at the entire discharge education. So just we created a consolidated version for the readmission families. So, this way, they using the BPA, the best practice advisory, so they actually automatically assign to the patient at the time of the NICU admission. Next slide. So this is what the flow diagram is showing. So the silent best practice advisory. So you can usually using the, but if you open the patient chart, so based on their birth encounter, if the baby was born at that encounter, so they actually get this full discharge education. But if they are readmitted, it's not a birth encounter, then they will get this small version of the readmission discharge education. So that's why they don't have to read entire discharge education. Next slide. So then we focused on this, we focused on this full education, then we had a consolidation education version. So this slide actually shows our demographics of maternal language and what proportion we have a non-English language preference families. And as you can see, we have majority of them, 89% speaks English and 4% speaks Spanish. And so, but we wanted to include everyone. So we actually included a specific for the Spanish speaking families. And so next slide. So in this version, so the Spanish speaking doctors, and then the help of our unit clerk and the Google translator. So we translated all the material into Spanish. Then we can assign this based on the family language preference. If they speak Spanish, they will be assigned to the Spanish discharge education. So I will show you the screenshot of how the families review that information in the next few slides. So this size is the one where family sees. So they actually sees this information in Spanish, and they have a book, and then they have chapters, and then each chapter has the same information. And videos, we actually have a subtitle, and then subtitle we translated into Spanish, so they can just read that subtitle. And so that's the one modification we did. And so then they can check off the same way that the other families do, just to understand or they have a question. Next slide. So the nurses on the other end, on the Epic, they actually sees this information as a Spanish parenthesis, and then they just whatever, all the information is in English. But once they sign off, they can see all the completion, everything, all the circles are completed in green. That gives us the information, okay, so the education was completed for this family. And so we do have a PDF printout for the families if they don't have any electronic access, or they don't have any, they don't know how to download on their phone. So we do have a printed copy available for the family, so they can take this home and then review that information and come to the bedside, and then they can check off all that they understand or they have a question. So we try to capture every level as possible as we can. Next slide. So this is how the optimization went. So we created this consolidated education point, and we translated to in Spanish. And so then we automatically assigned the education based on their birth encounter or readmission. Then we wanted to hear from the families. Okay, so is it really working, or how we are doing? So lucky for us, we actually have the follow-up phone call. So as a part of the family-centered care program, we do have a follow-up phone call program. So 4 nurses, right now we have 4 nurses, they actually call the families within a week or 2 after discharge and check in with them how the home transition went and how we can improve, and is there any way that we can provide better care for the future families. And so that's the way we wanted to hear from them. So next slide. So we, during that implementation phase, we actually asked 159 families and how they feel about this MyChart Bedside education. And 70% they used it, and 30% they haven't used it. And because they are short stay, they stayed only less than 48 hours, like a bilirubin, rule out sepsis, hypoglycemic babies. And so they are not able to access those MyChart Bedside. And whoever had access to that, then they said 92% they liked it. And 6% they preferred one-on-one education with the nurses, and 2% they declined to rate the MyChart Bedside education. So majority of them, they actually like this program, and they wanted this to continue. And next slide. They actually gave a good feedback. I just wanted to read a couple of them. It's a very good informative material, and it answered most of our questions and appreciated the simplicity of the iPad. Very convenient refresher for experienced parents, and smooth, easy to navigate, and self-paced. Next slide. So we wanted to hear from the nurses also, so because it's the change, it's a workflow change and how they feel. So we asked them about or how they feel about this program, and a majority of them, 92%, they actually liked it and improved the workflow on the day of discharge, and making teaching easier for parents as they had seen content previously and were able to ask better informed questions, and consistent teaching content and easy to keep track. Next slide. So any quality improvement work that we do, so along with the process, we have to look at this outcome. And so the next slide shows our outcome focused on MyChart Bedside usage. So as you can see, the yellow line is we separated in 2 different time period. The pilot period is the one where the nursing staff has to manually enter the checklist. As you can see, the usage is very, very, very low. So it's a 22% average in the pilot phase, the yellow bar. But when you see the optimization where automatically everything is assigned, so it got improved to 60%. So the parents viewed the MyChart Bedside more frequently, and then responded improved too, from 29% to 85% on the green line. And the red bar is actually the nursing time. So we just assumed 5 minutes of nursing time per education point. So then how much we'd have saved by using this MyChart Bedside. Family responded, I understand. So as you can see, from 3 hours per month average, we are able to increase that to 24 hours per month average. And I will show that in the next few slides. In the sustainability period, we are actually doing a fantastic job of like saving like a 55 hours per month. So that's how it's better response from the families and nursing staff and decreases the burnout. There's a lot of advantage of using this platform, and it's not easy and it's time consuming, but we can make it work. So next slide. So then as you can recall, so the original aim was we looked at the prepared for discharge Press Ganey survey and the top box score analysis. So our average was 47 in the pre-intervention, and then we looked at this, and then we were able to improve that to 70%. So our return response rate for Press Ganey is around 20%. So I actually look at this quarterly, provide a feedback to the leadership team. So it's actually we were with that return rate, we were able to show the improvement, which is fantastic. Thank you. Next slide. So the sustainability period, yes, we've completed this intervention in 2019, and so we wanted to see how we are doing it. So this is 2 years later, and as you can see with our amazing unit clerk, they are the one actually activate the iPad at the time of the admission. They actually activate scanning the QR code and then leave it at the bedside. The parents needs to put the PIN, so then they can have a full access to their account. And we were able to improve our average view and average response, and so average is like around 83 to 94%. Next slide. And then recently, it's not recently, it's last year, we looked at our data. So still we are consistently doing a 92 to 95% of the time they were able to review and then answer the question they were able to understand. Next slide. So we looked at our prepared for discharge top box responses, and then we were still consistently in the 70s, so which is great. Next slide. So what we did, what we were able to show that impact by doing this project is family received consistent information. And so it's not based on who's on and who's discharging the baby. If some nurses are really good with the discharge education, they do a great job, but it's not like that. So it's a consistent information was given and prepared well before discharge, and asked the questions based on the knowledge that they received or read. And it saved the nurses time, and it's also improved the family satisfaction scores about prepared for discharge. And also it's easy to update the content. It's kind of easy, and with the help of Epic Physician Builder, so we can just update the content in the Epic. We actually did the revision twice, and we changed our breast pump from one company to the other one, so we have to update everything. So it's just a little bit of easy to update the content based on feedback and changes in the unit. And we included every disciplinary staff got involved to provide better care. Nurses, MD, lactation consultant, unit clerk, marketing, IT, and families. So it's just a multidisciplinary way of showing that improvement. And families have access to this education post-discharge by accessing our website, or if they activated the MyChart website on their iPad, so that they have a full access to that. Next slide. So yes, every project has challenges, and I share some potential solution here. So physicians' time commitment. So it's just we did a volunteer, and I wrote the ebook, a volunteer formatted and uploaded in the iPad, all those things, and then Epic Physician Builder. So Dr. McCauley did the same way. So building the EHR BPA. All those things is a time commitment, and but we are proud to do that because we were able to show this big impact. And IT security. So original meeting with the IT was they are concerned about security issues on losing the iPads, but we actually share the family voices, how stressful the discharge planning. So we actually shared the family voices, then they were able to change their mind, and then they were able to have a full access. And in this 6 years now, we haven't lost a single iPad. So it's just still we have all of our 20 iPads and 5 iPads that donated from the Family Advisory Board. So we still have it in our unit. And the other concern is the staff are rotating trainees education. So we have several travelers, and then we have new trainees and new hires, the nursing staff. So what I did is we had a yearly refresher FCC orientation list. I actually do the one-on-one orientation with the trainees. It's just to go through the FCC activities. Same goes with the yearly refresher for our nursing staff, the orientation list. The other challenges is website content updating. So it go through the marketing. So there's a delay in updating. We still have the old version on our website, and it's time to update that information. Next slide. So this is the screenshot of our FCC orientation checklist. It just covers the entire topic under the FCC umbrella. So we include the discharge teaching as a part of that. So all the nursing staff that get their training. Next slide. The limitation of this project. So I know it was done in the 20-bed unit, community NICU. So you may have a concern about taking this to the children's hospital or high acuity NICU and all those things, but it's still possible. We can, once the baby is stable, if you're not giving this information when they're on ECMO, but maybe they come off of ECMO at the time of discharge, or they are stable, so you can still assign this education. Finding a champions to run the program. And if you already have the unit specific content, you can just translate, you can just convert them into the ebook, or maybe it's a great medical student project. So they can, or you can use the NPA guidelines and whatever you wanted to use it. So you can just change the convert and then use the ebook as a platform. Then we can have a, not available in other languages. So we have only English and Spanish, but you can request a fund and you can translate the material on your own. And so iPads, you can make sure if someone is willing to give a foundation funds or something, so you can add this MyChart Bedside pilot project, or you can use the MyCare on mom's phone as a proxy to access this education. And what if the families are technologically challenged and still everyone uses smartphone and it's easy to teach them. So you can overcome all those barriers. Next slide. So I will wrap this up quick. Next slide. So we don't want it to, this is it's not a replacement for direct bedside teaching. We still wanted the bedside teaching to happen. So we included that as a part of the education as well. Next slide. So we added the Spanish discharge education, as I mentioned, but you can go and then actually change the preferred language on your own. So that's where the instruction listed here. You can do it under demographic. Next slide. And once you do that, then you can delete all the English discharge education, and then you can just add the Spanish. Next slide. So we added the infant massage into this part of the TA discharge education. So they will get this information at 32 weeks. It's just a video and then short description of benefits, and then families can review this information too. Next slide. So we added the new breast milk pumping book because we changed our breast milk pumping company. So we just added that information. Next slide. This is my acknowledgement slide, and I think this is the end of our talk. So I just wanted to acknowledge everyone, and there's a few references. That's it. Sorry, Carolyn, I went over the time.
You did great. Thank you so much for sharing it. There was a lot of good chatter happening in the chat. So someone asked, and Carrie started to answer, how much of the discharge teaching is child as well as NICU unit specific? Could these be used in different locations across the country or the world?
Oh, I think they could, if they have their discharge education unique for their population, so they can just convert this into whatever format they want. They just start it with the ebook, they can do it, they can just convert that in the format. Or if they wanted to go to the MyChart website, they can have full access. They can, it's just they needed a content. Carrie, just jump in if you have any thoughts about this converting into
Jumping in
MyChart
on the
website.
chat to answer questions. People have just
Okay.
had wonderful questions, so keep them coming.
Okay, great.
To pull
Yeah.
a question, I think Betsy had mentioned this in Vincent's presentation about the importance of diagnosis specific discharge readiness and education. It seems like you've automatically sent most of these to NICU families. Do you have videos or education that are more diagnosis specific yet, or is that perhaps in the next intervention?
So we can have that. We actually have we don't cool the babies in our unit, so we actually transfer them out. But if you are a cooling center, you can actually add the problem specific discharge education. So we actually have a 3 problem specific information for the families using the NICU PET, the parent education material website. So we actually put that handout information on our education area. So for the ROP and RDS, and there is one more diagnosis. So we actually have that parent handout linked to that education section. Yes. So you can make it a diagnosis specific. That's easy to make it if you have the material. Yes.
Yeah, we have, just like you saw the book, that was a book for discharge education. We have a book for diagnoses. And what it does is it pulls directly from the patient's problem list. So if the patient has jaundice on their problem, it assigns them the handout for jaundice from the NICU PET website. It's also nice because it will assign, it gives the handouts in all of the languages, so English, Spanish, and Chinese. So we don't even have to know what the parent's preferred language is necessarily. We can just go ahead and give them all the handouts.
That's fantastic. Thank you so much. Thank you, Malati. I know that it's really encouraging to hear from someone, especially you didn't have funding. And so to have this, I think, is a really wonderful opportunity that you asked for what you needed, and your Family Partnership Council was able to help you with that in your administration. So thank you so much for sharing that. In our last couple of minutes, if you have other questions, drop them in the chat and Malati can respond. We did want to show you our new website. So if you go to fcctaskforce.org, you'll be taken here. So we've shown you our Padlet in the past. This is our brand new website. So you can see under webinars, all of the recordings and slide decks. Under resources, these are things that we've linked to or that presenters have linked to, or that things that you all have shared that you have found really valuable as part of the listserv. So please make sure you check that out. If you have any feedback, let us know. And then I want to just sort of show you a wonderful video that features some of our family partners, and we can have this to end our session today.
I came into my preemie experience already having gone through the trauma of infertility and already having that, at first I thought it was guilt, but it was shame. It was, I am not a good mother. I can't even get pregnant, first of all. Now I can't stay pregnant. Now I don't know my babies.
The trauma, it begins at delivery and then it just continues throughout until you get to discharge. And then you're processing.
As NICU providers, to take on all that emotion by someone, you'll just be fried by the end of the day, right? But leaving it absent and not addressing it doesn't allow for very good family-centered care. And I think a lot of it relies on communication.
Personally, after I gave birth at 24 weeks, I felt such guilt that I failed the boys, that I was like, now they're in the NICU, they're where they belong, they're with the people who know how to treat them, and they don't need me. I was lucky enough to be in a hospital that had a very strong family-centered care plan, who, before I could even verbalize that, said to me, you're going to change diapers, you're going to take the temperature, you're going to feed them, you're going to hold them, they need you. And I needed that to know that, I was supposed to be there.
After that first month, one of the nurses said, she said, have you held Avery today? And I haven't held Avery ever. And she said, oh, well, we're just going to make that happen today. And I was like, oh, I don't know if I can do that. But she said, we can do it. We're going to do it together.
Simply asking how my day was, or having a conversation with me that has nothing to do with the NICU or babies or monitors or me being get the world to me.
In any kind of an ICU situation, your relationship with your partner is at its most fragile, because you're both going through the hardest time of your life together with your child that you both love more than anything.
And I think another concrete thing that's super important that often gets left out, that our family experience, is not having adequate discharge planning. You know, you go from having this like super high intensity experience to sometimes going home from having had a one-on-one nurse to being alone with your child, just saying like, hey, it's a big change to go home. If you have questions, this is where you call. You're going to have questions. That's okay. You know how to do this, and it's scary. So I think, you know, just kind of naming that for families and helping people understand that you can be a good parent and be scared.
For NICU parents, you know, this is again a life altering event that in the NICU, we are there because we have to, because that's our kid. We are resilient not because we want to, but because we have to. At the end of the day, as NICU providers and NICU teams, that you could go home, you could change jobs, you could do whatever you can. And again, not to say you don't care, because I know you absolutely care about your families and your kiddos. For us, that's our whole life.
Thank you so much to all of the family partners who were part of that video, for allowing us to share and hopefully amplify your voice in this. We do have a couple of upcoming webinars. You'll be receiving calendar invites for these if you're part of the listserv. We have some amazing content coming at you, and this is all a reflection of things that you have named or that our family partners or healthcare partners have named are absolutely vital to providing this work. So thank you so much for all that you do. You know, we've all been inspired to say, I think, by so many different wonderful options and resources. Start small, pick something that you're going to work on in the next week and try to find a way to make it happen. So thank you so much, and we will see you all in May.
Thank you. Bye.